Okay, hello everyone. So before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day, and on whose traditional territories our work takes place. We acknowledge a debt to those here before us and recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have with this land. My name is Keshni Selvaganesh, and I'm the Administrative Assistant for the Canadian Coalition for Green Healthcare. And on behalf of the Coalition, thank you so much for joining us for today's webinar, Low-Tech, High-Impact Solutions to Heat Waves in Long-Term Care, Acute Care, Clinics, and Home Care Settings across Canada. Throughout this event, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and our panelists will be answering questions at the end of the event today. We will also be recording this presentation, which will be sent to all registrants and will be available on our website and YouTube channel at a later time. So now I'm really excited to introduce and thank our amazing speakers for being here and sharing their knowledge with us today. So first off, we have Dr. Miles Sargent, who's the Executive Director of the Canadian Coalition for Green Healthcare. Dr. Sargent is a family physician who has worked with vulnerable populations, including new immigrants and refugees, people experiencing homelessness and/or addictions, and the elderly over the past 25 years. Recognizing the intersection between environmental issues and health, he is dedicated to addressing climate change issues and has co-founded Partnerships for Environmental Action by Clinicians and Communities for Healthcare Facilities, the charity Trees for Hamilton in 2012, and the not-for-profit Shelter Health Network in 2005. We're also joined by Dr. Diane Machino. Dr. Machino is an MD psychiatrist, education scholar, artist, and associate professor at the University of Toronto with prior experience in primary care. Motivated to improve access to mental health care, she completed formal training in healthcare leadership and complex system transformation. She was an early women's health pioneer, founding and leading trauma-informed programs for unserved populations having mental health needs. Her current focus applies the discipline of leadership to frame and address challenges pertaining to planetary health, social inequalities, and declining health outcomes. She serves on RCPSC's Planetary Health Committee, Senecondu, and is an affiliate of the World Health Leadership Network. Next, we are joined by William Gagnon, who is a Director of Implementation at the Canadian Coalition for Green Healthcare. He's an expert in healthcare systems, decarbonization, and sustainable medicine. As the Director of Implementation, he supports healthcare leaders in decarbonizing their practices. William holds a bachelor's in building engineering and a master's in bioresource engineering, and William is also a project management professional. He studied climate and leadership at Harvard and Cornell. He's also part-time an executive director of the Northwest Territories Medical Association. With that, I'd now like to welcome Dr. Miles Sargent to start us off with a look at the impacts of extreme heat on our bodies. Take it away, Miles.
Right. Thanks so much, Keshni. And thank you all for coming today. What a really good turnout today. So yes, I am a family doctor in Hamilton, and I got into the environmental stuff actually because of a hot day downtown Hamilton in around 2010. And interestingly, I've been involved with a hospital evacuation due to fire in Hamilton. So this whole topic hits home for me. The presentation that I will be doing was done for the Canadian Family Physicians group last summer. And if you're interested in that, I think I show a link to that in a second. So thank you to them for allowing me to use these slides again. I have adapted them for today. No real conflicts of interest there. I've listed all the various things. Next slide, please. Okay, so what are the sources of heat and increased temperature in Canada? What are the ways one can be exposed to heat? And how can we assess for exposure. Next slide. So I'd like to start with this one, which is obviously a picture of someone running. I assume it might be a marathon. When we think about people suffering in the heat, and certainly things that make the news around the world, it is often people who've died in a marathon or the young football player who had too much equipment on, pushing too hard middle of the day. And these are clearly tragic deaths, but they are not the typical death. Next slide. This is the more typical person who would die in a heat wave, elderly person, potentially chronic medical conditions, actually indoors, not outdoors. Next slide. So again, what are the sources of heat and increased temperature, not just in Canada, but in the world? Next slide. So now I'm going to take you back to your grade 6 geography class on the left. We'll focus on the left first. The greenhouse effect, I'm sure you know this, but I'll just review it again. So number one, sun's rays passing through into the atmosphere. That is normal. That has always been normal. Number two, sun's rays, some of them deflecting and not getting into the atmosphere. That is normal. Number three, sun's rays coming in and being held inside the atmosphere by greenhouse gases like carbon dioxide, because the greenhouse gases have what is called global warming potential as a molecule to hold heat. This was also normal. CO2 has always held heat, but there's so much CO2 now and other greenhouse gases, we have a problem. And then the slide on the right shows the contribution of various greenhouse gases to global warming. And you can see CO2, and this one is actually 82%. That's an American slide from about 7 years ago. I think some suggest it might be 75%, but nonetheless, CO2, dominant gas, and mainly from the burning of fossil fuels. Next slide. And this goes all the way back to 1880. The yellow line, pretty steady increase over years. And then, as you can see, about halfway along there, it takes a turn and starts to become a bit more exponential. So that's the carbon dioxide curve in yellow over the years, going up and up. And then the corresponding temperature rise, which is a direct relationship there with temperature going up. Obviously, year to year, a lot of variability. Next slide. Okay, and what are the ways one can be exposed to heat? Next slide. This is a slide that I love by Dr. Jonathan Patz, who's from Wisconsin. And his basic graphic here starts with the impacts of global warming. In the middle, rising sea levels, rising temperature, and weather extremes. And then you can see in the next ring some of the more direct impacts that we see on human health. And then what I've done in the two columns there is put it into a Canadian context. So if you start at 12 o'clock with air pollution, asthma, cardiovascular disease in green there, in Canada, one of the things that we see, of course, is a lot more forest fires because of global warming, and those, of course, impact our respiratory health. I guess I'll go next at 2 o'clock there. What are called vector-borne diseases carried by insects. In Canada, that's Lyme disease and West Nile virus. Also, moving further north, I'm going to skip all the way down to 7 o'clock. Increasing climate anxiety in all countries, especially in the youth, but in any number of people, big problem. And then finally to our topic today, up at 10 o'clock in purple, heat stress. So this is actually of all the different climate disasters, this is the number one cause of death in Canada, and we need to be careful about our, what I would call our vulnerable populations. Next slide. This slide, and I'm sorry it's kind of small here, is by University of Waterloo Intact Center. They have some wonderful resources on climate resiliency and various issues related to that. All the small dots, either circles or triangles, are cities or towns across Canada which are most impacted by severe heat. You can see them written out there. Quite a few of them all across the country. Interesting, though, you do not see Vancouver, you do not see Victoria on here listed as at-risk cities. Why is there a huge orange circle in Southern Ontario? That's basically the population that might be impacted. We have not had a heat dome in Southern Ontario like the heat dome that was seen in BC a few years ago, but you can see the impact it might have in bigger centers. Next slide. I've always been interested in this. I have grown up in Hamilton. I've been here for quite a few decades, so I have seen things change over time. There was a time in around the 1970s or so where Hamilton would typically only see about 8 days over 30 degrees per year, and now, as you can see, we're seeing 18. These are the list of the hottest cities in terms of number of days over 30 degrees, and these are the ones we need to worry about. Kelowna has the most, Windsor, southernmost point in Ontario, or at least as a city, 23, all the way down here. So a lot of these are Southern Ontario, but a few for me surprises. Saskatoon to me was a surprise. Obviously, as Canadians, we joke about winter peg. You could also almost call it summer peg here. And Ottawa is in there as well. So a couple surprises to me on this list, maybe not to people who live in those towns. Next slide. So this is the coroner's report on the heat-related deaths from the summer of 2021. This came out a year later. Next slide. So this is the forecast for the beginning of the heat dome. And look, a lot of us are on our phones or whatever media source we use and can see this coming and can be ready and can respond to it. And I imagine part of that forecast might have said that this is not going to be just 1 or 2 days, which might be a typical thing. This is going to be a few days. But then there's a lot of people, including the people that I might work with in inner city, who are not on the pulse of the weather and so are not responding to this in time or getting some other option. Next slide. So this was a tragedy, 619 deaths as a result of that extreme heat. And I'm just making this simple here with the yellow highlights. What were the variables that the coroner's report found? Number of days of the event was significant because this just kept going and going. The height of the temperature being so severe, how accustomed people were. Like, keep in mind, this was in June. Potentially, if this was in August or later in the summer, people have adapted more to heat. Ability of the community to respond to the disaster. And again, I'm not pointing fingers by any means at all. I don't know if any place in Canada is ready for this. But when you have cities that don't typically have this kind of heat, the community doesn't even have air conditioning. And then what actions were taken to decrease risks, especially for the most vulnerable. Next slide. And then, and let's keep in mind, we're talking about people here who've lost their lives. I don't mean to turn them into data points. So what were the common factors? Again, most of these people did die indoors and lacked access to a cool building. Most were older individuals. Most, interestingly, did communicate that they were feeling unwell and clearly did not get to the doctor, the hospital on time or at all. And then, as you can see, in terms of chronic diseases, I mean, that is a really high percentage. Over 80% of people had more than 3 chronic diseases on their medical record. Next slide. So when I first looked at this coroner's report, I saw that this line in terms of number of people dying, and across the bottom there on the x-axis, the age group dying, you could see a definite increase. But that was an increase without even looking at per capita age groups. So we simply took BC's population by capita and kind of divided it in. And then this shows you kind of more accurately heat deaths per age group, and obviously exponential. Next slide. So how can we assess for exposure of heat? Next slide. So that is the link to the webinar that we did last summer with my colleague, Dr. Emma Coe. If you're interested in more detail, we do go into some of the medical details a bit more, and we gave a case history of a woman, 78-year-old woman, who might be presenting to your office or could be presenting to your emerge department. Next slide. if someone is presenting, and again, this was directed for family physicians, this talk. If someone is presenting during the middle of the heat wave and you've got dozens of people coming to emerge with heat-related symptoms, it's not hard to make the diagnosis. So this is almost more for the situation where you've got the individual who is maybe in the worst case in one of the hotter buildings on one of the higher floors, has more chronic diseases, is on medications, which are problematic for a heat wave. And sorry, if you just go back and say, if I'm going too slowly, let me know, Casey. So DDX means differential diagnosis. So for a physician, what are you thinking about when someone comes in with a high temperature? And we may not be thinking about heat as the first thing. We might, sepsis is overwhelming infection. That might be the first thing, or potentially a brain hemorrhage or medication side effects. So we're just sort of saying to the medical community, we need to be alert to heat coming in as a presentation. Next, sorry. And then digging a little deeper here in terms of the differences of heat exhaustion or heat stroke. And most of these things are progressions that you that you would expect to see. For example, like someone's cognition, ability to think, decreasing their heat stroke, item number 2. That's obviously a natural progression. But some of these things are paradoxical in that heat exhaustion, the earlier phase, you'll have increased sweating. But by the time you get to heat stroke, you can have dry skin and you're not sweating anymore. Next slide. So the natural thing, our body temperatures are 37 degrees normally. And so that's why getting over 30 degrees temperature becomes problematic for humans, because now it's harder to release heat in a radiant way. Obviously, we also sweat, but on a humid day, you cannot release heat by evaporation as easily. So these are some things. A hot, humid day is more problematic. Next slide. This might be a bit too much detail, but just definitions here. Heat exhaustion, showing what the core body temperature is over 38, and then getting to heat injury. AKI means acute kidney injury. And then rhabdomyolysis, which is breakdown of muscle, and liver failure. So getting extremely serious here, and then heat stroke, often fatal. This is immediate medical intervention on the right. I would say you're looking at it in the middle here. Next slide. So this is a thank you slide to people who helped with these slides last summer. And I just do want to let you know, Diane is going to be repeating some of the things I talked about today. And so hopefully they get reinforced. Next slide. And some references. Thank you. And I think I'm passing to Diane.
Okay, thanks. I'm unmuted. Thanks so much. So you've heard a little bit about who I am. I got involved with climate change leadership because leadership and health system change are part of my academic work. And I said to my colleagues, we dare not call ourselves leaders if we don't deal with the most important health concern that has faced our planet. And I have the honor of being the leadership advisor to the coalition. Next slide, please. So with this heat adapt research and implementation project, our goal is keeping people out of the danger zone that Miles was talking to you about. And I'm going to tell you about why we are, the other factors that are important in terms of why we need to do these projects. We've been focused globally on mitigation. However, countries have essentially made no progress in cutting emissions and tackling global warming. That's a study that came from the United Nations, October 2024. That is not to trivialize the very important work that has been done in tackling emissions by many, but globally, collectively, we're not making good enough progress. We also know, and extremely well, north of the border, that politicization, disinformation, and communication strategies impact our ability to get the work done. In some ways, it's got to come from health. It's a great place for the work to come from. So we know that adaptation and resiliency strategies are needed to combat extreme heat in the health sector. So that's the negative information, which is not a great communication strategy. The best communication strategy is that it's good for people and good for the planet. It saves lives and it saves money. And you will see over on the right-hand part of the slide, data that comes from many countries that are looking at global average temperature change. And this is the consensus that they all agree on. Okay, so next slide, please. This slide refers to the BC heat dome, where we saw that hospitals and health facilities were overheating and had to call in fire services to hose down the buildings to keep the people inside from literally cooking. That's heat stroke of both the patients and the health providers. I generated this slide from AI because there's not a single photo I can find of this, although we know this is what they did. A picture that is on the internet. So again, coming out of the BC heat dome, which was in 2021, you've heard from Miles again that most of the related deaths were amongst older adults with compromised health conditions who are living alone and inside. On the right-hand side of the slide, I want to emphasize something else, which is that in a single day, there were 12,000 911 calls. Just imagine 12,000 911 calls in one day. And offloading patients to the hospital were delayed because the hospitals were overloaded and they couldn't take anybody off the ambulances. So the ambulances were clustered in the parking lot, not able to respond to others who were in need of help, which was again another source of death. Next slide, please. This slide, again, part of our why we need to do this. This study showed that 1 in 5 Canadians in 2022 were very worried or concerned about climate emergencies, climate and weather-related emergencies. Maybe that's a little bit more now, but we're still not doing well enough with level of concern. And and then 1 in 4 said that they had actually taken some actions to prepare against the potential weather-related emergencies. Excuse me. Next slide, please. We've talked a little bit about who's at greatest risk between Miles and some of the data I have reviewed, but I want to emphasize that it is not only the old people, but also the very young who are at risk. And one of the populations I deal with, which is highly complex medically in need children, many of whom are on life support, both at home and in hospital. It's our marginalized or vulnerable populations, systemically marginalized, which is the thing that creates the vulnerability. Interestingly, females are more at risk than males. Mentally ill, we know who are at great risk. Not only because they may not know how to respond if they're depressed or psychotic, but also because of their medications, which impair their capacity to cool. Those who live alone, those who live in dwellings without cooling, and those who have medications that impair cooling, not only from psychiatric medications, but other medications. So in summary, from this slide, indoor temperature does not equal outdoor temperature, and the risk is not the same for all. Next slide, please. So the built environment is very important and it influences indoor temperatures. So we know if you look at the infographic on the right, we know that windows which are large, that face south or west, windows that take up more than half the wall space, and top floors increase the temperature, the indoor temperature. And I noticed that even going from my first floor to my top floor of the house, which is 3 stories. And then on the right-hand side, we know that mechanical cooling, surrounding greenness, facing north, all lower the indoor temperatures of our built environment. Next slide, please. Another important factor that Canada needs to deal with is that over the next 20 years, our population of seniors is going to grow by 68%. So we're going to go from 6.2 million in 2017 to 10.4 million in 2037. Not only is the number of the population of elderly going to increase, they're going to increase by proportion, which I think may be on my next slide. So here we see it again. It's one of the fastest growing demographics, which means that proportionally the elderly represent more of the population. And almost all Canadians want to age at home as long as possible. They also use more of our healthcare services, not surprisingly, as health needs become more complex. And they get to a point where they need 24/7 care in long-term care facilities, and we need to adapt that care setting. Next slide, please. So the average monthly temperatures in the summer, as you can see by the red compared to the gray, is going up. So that's and that's really across the board in these cities, as you can see, with the occasional one that is not increased. And press the next button, please. But what is really important is that maximum temperatures are the killers, not the average temperatures. Next slide, please. This is from a study done in Vancouver in 2021 to 23 about the kind of symptoms that people living in households reported. And so it was at least one heat-related symptom related to heat that impacted their ability to manage throughout their day. And I want to spend a moment on this slide to point out what Miles has already talked about, which is headaches, trouble concentrating, being dizzy, drowsy, nausea, vomiting, trouble breathing. These, and then confusion, these are the symptoms for mild heat-related exposure. And any of us who've been outside on a very hot day may have experienced these things. The trouble with these symptoms is that this is the time that people need to respond and prevent themselves from getting into severe problems. But when you're dizzy, when you can't concentrate, when you can't breathe, and when you're confused, it is very difficult to take the actions to cool yourself down that you need to take. So we need to figure out this adaptation. Next slide, please. Next slide. I don't know that I can move them. Thank you very much. So another piece of information about why we need to do this project comes from a study done in Portland, Oregon, and it was during the heat dome. The 3 highest risk days, they had they used passive cooling in the extreme Pacific Northwest for the first time. They showed that could decrease the indoor temperatures by 14 degrees Celsius. I think that's Celsius, right? I can't see it, but I think it's 14°C. And that without the intervention, indoor temperatures were dangerous and predominated all 72 hours. So even at night, they couldn't manage their indoor heat. So what did they do? They used shading, passive ventilation, and it also showed that they reduced their aircon load by 70%. And this is applicable to other regions and countries. Thanks so much. Next slide. So in keeping people out of the danger zone of heat stroke, we can close the windows, fully shade them from the sun, managing this with east-facing windows in the morning, west and south at night, or in the later part of the day. We can use makeshift inserts for the entire window area. It doesn't have to be expensive. And then we can actively move cooler air indoors at nighttime. And then building owners can install shading on tracks to be moved over the windows when needed. Homeowners can green their properties with shade, trees, and open windows appropriately to create ventilation to cool the house. Press the next button, please. So this is a picture of someone putting cardboard in their window, and it's that simple. And we can do this, and we need to get that information out there for prevention. Next slide, please. So what we need to do with this study is to assess these low-cost options to reduce indoor heat and look at both mechanical cooling, which we will need to some extent in our homes and healthcare facilities, but we can decrease the need by using passive cooling, including greening around our healthcare facilities and around our communities, increase our shading, natural ventilation, blocking the sun, and increased insulation. So I'm repeating myself there, but that's what we're going to assess. Next slide. I want to emphasize that there's another piece that's very important here, taking us back to science, is that our air quality worsens with increased temperature. Oxygen is converted to ozone by a very simple equation, which is sunlight bringing oxygen, volatile organic compounds, and nitrogen oxides in our air, which are there all the time. And the sunlight increases the transfer of oxygen to ozone at the ground level. So our air quality, and that's a pollutant, so our air quality at ground level gets far worse, which makes it much more difficult for people with respiratory and cardiac illnesses. We can manage that with masks, filters, and staying indoors. Next slide, please. This relates to our climate-related projected costs. And across the bottom, on the left side, you can see high emission scenarios and low emission scenarios. What I want to show you is the right-hand part of the slide, where you see the projected impact of ground level ozone on death, the cost of this with low and high scenario. It is off the scale. Next slide, please. So the need for our project is related to the fact that the number of extreme heat days is going to increase. Miles mentioned that. Most areas noted for heat do not have mechanical cooling. People are not conditioned to deal with heat, and that extreme heat can overwhelm emergency services. And our healthcare facilities are old and they're not equipped, and we need to ensure that they have backup power generators and that they can supply enough power for our absolutely required medical equipment and to keep the building cool. Home generators are expensive, but way more expensive not to use them. Next slide. So in summary, the need for our project relates to aging populations who want to live at home, our vulnerable populations who are most susceptible, and our need to explore low-cost strategies. Next slide, please. So that's me. I think I hand it over here.
Thank you so much, Diane. This is very informative. I think you really speak to the urgency of this work. Kishni, I'll take over the screen sharing from here, if you don't mind. There we go. Thank you. Can you see this? Diane, can I get a thumbs up from you?
Yes.
Okay, great. Awesome. I don't see folks anymore, but
It's loading. It says it's loading.
loading. Okay.
Yeah, now we see it.
Okay, great. Yeah, thank you so much, Diane, Miles, and also Linda and Fiona and Kishni, who've put like an enormous amount of work on this project, and also like our many, many partners on this. I'm thinking of Raluca, I'm thinking of Rob, who I saw in attendance. And there's a lot of people that are working on this, and I'm pretty excited to be part of this project myself. So our goal here is really to make sure that we decrease the heat health impacts of vulnerable population in health delivery settings. So we need to increase the resilience to extreme indoor heat in healthcare settings to protect the most vulnerable, as Diane, you mentioned. So we'll be working directly with health workers and patients, residents, and organizations representing at-risk and vulnerable populations. And the goal of this project is really to make sure that we equip those places where vulnerable people stay with adaptations that will reduce the heat health impacts. So we can reduce the indoor temperature and keep those people out of the danger zone, as both Miles and Linda mentioned. So this project has many components. So we'll be doing both qualitative and quantitative assessments in healthcare facilities in British Columbia and Nova Scotia. We'll be analyzing this data, and based on the data, we'll be coming up with solutions that we'll work on implementing. So that'll be this summer. And then next summer, we'll be implementing those solutions and reassessing a baseline of qualitative and quantitative data. And then identify which of the solutions that we will be implementing work best. And then we'll follow up and we'll distribute this information across the country to make sure that as many people as possible have access to it and can implement it in their communities, with some workshop delivery in communities to share their project results. So this is a repeat of the last slide, but in a more visual way. So you see here, we're here at the end of March 2025. We'll be starting our baselining of the data for this project, which means we'll be collecting surveys and interviews and temperature and humidity in the different locations we'll be using for our project. Towards the end of the summer or in the fall, we'll be analyzing the data collected. And then with this data, we'll be able to identify which of the solutions that we should think of implementing. We'll be implementing those solutions in the spring of 2026. And then in the summer, we'll do a second round of data collection to see, has the indoor heat temperature changed? Are residents doing better? Or how are those solutions performing? We'll then be reviewing that and then sharing our lessons learned in 2027 with a lot of workshops with various members of the community. I'm seeing a lot of activity in the group chat, so we'll come back to it in a little bit. And there's other deliverables as part of this project. So we'll be looking at the impact of high heat on medicines for storage, for transportation, but also for the impact on patients and residents. I work for Doctors Without Borders myself, and I remember that we had to keep our warehouses to 25 degrees Celsius or cooler in often areas that are much higher temperature than that. So that required a lot of energy to keep medications cool, because otherwise the medication would be ineffective. We'll be also looking at guidance for radiology equipment and the impact of high heat. So to prepare those radiology departments for high indoor temperature. We'll do some scenario planning with community workshops where participants will be trained to anticipate the climate health episodes and develop adaptation strategies. And of course, we'll be disseminating that through the country in bilingual infographics, toolkits, and videos. So we kind of gave you an overview today of the project. There's 4 big pieces of data collection that we are going for. So the first one will be interviews and surveys with healthcare workers in the sites that we'll be selecting. Then we'll also be doing interviews and surveys with patients and residents, as well as a building survey. So what does the building look like? What are the windows like? What's the shading properties? Diane was showing some pictures of buildings and how the design of buildings impacts the indoor heat of those buildings. And finally, we're also installing data loggers, and those data loggers will be collecting temperature and humidity data throughout, probably starting in mid-May 2025 of this year, and then collecting this all the way to 2027, so we can see if the implementation of our solution, so that, shading or reducing heat gains has an impact on residents and patients, and can therefore eliminate the danger zone for, or at least keep them out of the danger zone as much as possible. So I'd like to tap on your collective wisdom here, and so I'd like to invite you to use either your phone or the link here. I'll be pasting the link in the group chat in 1 second here, so you can use this link. Click on there, and I'd love to collect your early idea. So we're really, so we saw all these impacts of heat on the body and on our communities, and now we as we are starting to collect the data, we also need to think about what are the different solutions out there for heat adaptation. So I'll invite you to go on there, and I will be sharing here the screen. So I put my favorite one, which is yogurt paint. So this is something that was recommended to me by my algorithm. Some people are painting plain yogurt onto the outside of the windows in order to reduce the heat gain. And so that's a very low cost solution. So please don't hesitate to put in some ideas on here. We'll be taking notes of them and investigating them and seeing how we can try them out across the country. I love it. So I'm seeing shading, well-maintained HVAC systems, window shades, curtains, shading. Yes, cardboard, which is also shading or preventing the heat gains. Don't use this outdoor, putting feet in ice water, foam on windows, cardboard, dark shades, educational strategies. Wow, there is a lot. Keep them coming. Wind, air circulation, portable fans. Yes, I spent the last year living in Singapore, and initially I was making fun of my colleagues who were carrying those portable battery fans, but then I quickly bought one for myself because I thought they were pretty nice. Better building insulation, that's correct. Trees, heat pumps, of course, air conditioning, of course, increased fluid intake. Wow, there is a lot. So obviously, the solutions we'd like to implement are low cost and low energy ones as well, because we know that air conditioning units also have refrigerants in them that can contribute to climate change if they get released to the atmosphere, which ultimately they will be. So I think this is also why we're going for low tech and low cost solutions. I love it. Keep them coming. And I'll go back to my slides here. Keshni, did you want to cover those slides, or do you want me to cover them? I'm happy to cover them.
Go ahead.
All right. Yeah, we have a ton of supporters on this project. Oh, did somebody talk? No. A ton of supporters on this project, and all across the country. Fiona Parascandalo at McMaster, Dr. Ingrid Waldron, Dr. Suchanik with Peach Health Ontario, Hardin Henley, of course, Dr. Machino, Dr. Moore Brown in radiology, the Canadian Association of Pharmacy for the Environment, led by Shalaja Sajwani, and Dr. Linda Lukasik with the City of Hamilton. There's a ton of people working on this that we're getting ideas or collaboration or input from. So thank you so much for your time. And with this, I probably will pass it back to Keshni for our Q&A. Or I see Miles has unmuted, so maybe I'll let Miles first.
Yeah, Keisha, I didn't mean to steal your thunder. If you want to jump in, do you want to go ahead? I have a question, but you go ahead, Keisha.
Yeah, you can go ahead. I guess the next thing would be the Q&A, but please go ahead.
So first thing, there's an ozone question which hasn't been answered, and I'm going to maybe ask Will or Linda to respond to that one. So I'll give you a second to respond to that. And I want to ask a question that's kind of come up indirectly. What if we're not involved and we want to be involved? Can we, right? You know, like if I'm in a city or someone's talking about long-term care, I mean, how much capacity do you have to add new partners or sites?
Very good question. I'll take this one. If you want to get involved, you're interested about this project, please email me and Keshni. So I'm at william@greenhealthcare.ca and Keshni is at keshni@greenhealthcare.ca. We'll be very happy to chat. There's lots of opportunities to get involved and participate. We're looking for data all across the country. So that will not be an issue. Maybe Keshni, you want to read the questions in the chat and we can answer them one by one?
Yeah, of course. So we'll start off with the first one, which is about the ozone. So it's shocking to see the scale of ozone-related deaths at this point. I don't really believe most healthcare facilities track ozone as part of the IAQ monitoring. I wonder what is a safe ozone amount, or where should we go to learn more on how to manage ozone for HCFs?
That's a very good question that I cannot answer. I don't know if there's a safe amount of ozone. Diane, are you able to answer this?
I am not able to answer this, but it's a great question, and I will dive into what a safe amount is and actually who's doing the monitoring, because clearly someone's monitoring this. Miles, Linda, do you have any comments about that?
You know, I'm hoping Linda does. This is actually something that come across. Yeah, you know, yeah. So you always ask Linda when you don't know everybody, all the 130 people out there. You ask Linda. Okay, so here we go, Linda.
I don't know. Sorry. But I think it's an excellent question, and we should bring it forward because, as Diane pointed out, it contributes to the mortality of folks subjected to high heat. So we have to figure out how to include something on ozone in our project. So thanks for the question.
You can tell from Linda's voice that we ask her a ton of questions. Thank you again, Linda. Yeah.
Can I pop in with something?
Yeah.
Yeah, the other thing, so there was also a question in there about smoke and fire, and the reality is, you know, our grant was focused on extreme heat because that was the grant call, but there absolutely will be co-benefits related to fire and smoke, and we are very focused on that in terms of just thinking about air quality. One of the things that concerns me is how fast we need to move, because we've got a lot of distractions right now, both politically and socially. And I just came back from an urgent situation up north. We were scrambling over downed wire electrical wires and, climbing over ice-covered trees and under branches with the wires like spaghetti on the ground to get back to the city. These things are happening everywhere, and we only deal with the thing that's right in front of us. But we need to be thinking further out. So all the collaboration we can get, the better. Thank you so much, everyone. And thank you to our partners and Linda for leading us in this.
Kashni, unless we're wrapping up, I'm going to jump in with a couple of things here. Are we wrapping up, Kashni, or we have a couple of minutes? Yeah. Okay, I'm going to see if Arden is still out there, because I would love Arden to come on and talk a little bit about GTEC. And if he's not on, he's driving or something, my apologies, Arden. What Diane challenged me about a year ago, I was part of a webinar, and Diane threw out a scenario, which was a Southern Ontario scenario where you have a heat wave, which is quite bad. And so we as a group are kind of talking through, okay, what do we do about this heat wave? It's a massive heat wave. And then Diane cut the power off to the city. I didn't think that was very nice. But it's actually realistic. Like that is when you have brownouts, and that is when people's air conditioning breaks, right? And I didn't have a great answer for that without thinking a lot about it. The point is, a heat wave like that overwhelms our health system. And so can we do things within the community? And so that's why I threw this out to Arden. So Arden, pop on whenever you like. And in terms of the cardboard question covering the windows, I mean, I suppose you could have a setup where you're putting the cardboard up and taking it down every week or so if you want to clean a little bit. But I don't think that should be a problem. Arden, are you able to speak about GTEC and some of the work you've done? Need to unmute. There he is.
Okay. All right. So the Green Technology Education Center, I'm the executive director, Arden Henley. I'm delighted to be a part of this project. And I think to say what GTEC's contribution is first of all, we have some unique skill sets in appreciative inquiry and scenario planning. And I think beyond that, I think we're systemic thinkers, and thinking of the medical service delivery system as a system is really important. And so it's been a tremendous learning experience to be with you today, and it's helped me conceive of the project from that systemic view. I don't think this is the moment to share that, but suffice it to say that our team is delighted to be a part of the picture and contribute, as I said, systemic thinking from community development and education points of view. Back to you, Miles.
Thanks a lot, Arden. Thanks for all the great work you're doing. And any other questions that have popped up, Kashni?
Yeah, so amazing. We do have a few questions. There's a question, is there any capacity within the project to assess the value of temperature monitoring and emergency response health plans in long-term care homes, or is it just focused on direct health interventions? I'm wondering if there is a gap in long-term care or emergency management planning that could be addressed or assessed in this project.
So maybe I'll speak to the data monitoring part, and I think that will also answer Kelly Lim's question in the chat. So Kelly was saying, I was wondering why you don't also track PM 2.5 and ozone as part of your data logging, in addition to temperature and relative humidity. So to clarify, we're collecting indoor temperature and relative humidity, which means that we have to go and install some data loggers and sensors in people's homes, connect them to Wi-Fi, and remotely collect this. For PM 2.5 and ozone, that's already collected with Environment Climate Change Canada data, so weather data. So we'll be able to pair that together. I can't speak to heat preparedness just yet, but maybe Miles can. Keshni, can we unmute Miles? I think he's struggling with.
Yeah.
Oh, so sorry. Gosh, so much drama. I was trying to type an answer in the chat about the medication question, and I just kind of doing my one finger typing there, concentrating so hard. What is the question, William?
I'll ask it.
Right, you're talking to me? Yeah.
So
Keshni?
yeah.
Yep.
So is there any capacity within the project to assess the value of temperature monitoring and emergency response heat plans in long-term care homes? Or is it just focused on direct health interventions? I am wondering if there is a gap in long-term care emergency management planning that could be addressed or assessed in this project.
Yeah, excellent question. Hey, I'm the boss. I don't know these things. Linda, Diane, can you bail me out here?
No, you have to tell me the question because I was reviewing some of the questions in the
One
chat.
more time, Keshni. And it's a great question. It's a great question. Yeah.
Is there any capacity within the project to assess the value of temperature monitoring and emergency response heat plans in long-term care homes? Or is it just focused on direct health interventions? I'm wondering if there is a gap in long-term care emergency management planning that could be addressed or assessed in this project.
So part of the project is focused on long-term care. And one of the other things that we will be doing as well is scenario planning, because if long-term care facilities are not, they don't have adequate plans, that's the whole point of the scenario planning, is that we get multiple sectors together to figure out the right approach to both prevention, treatment, and emergency response.
If I could just add, in our surveys and interviews, we do ask about whether or not the facility has heat plans, whether these heat plans are integrated into their emergency plans, and if they don't, whether they have some kind of guidance for dealing with heat. So those kinds of questions are being asked so we can assess further. Thanks.
And it's not a large number of facilities that we're dealing with. The grant money is relatively small, so we will deal with a couple of facilities, and then we'll have to scale this out across the country, which is also critically important. Could I jump in and answer one of the questions that Rob Samoluk asked, which is related to the need for generators? So Rob, you asked the question, will this not greatly exacerbate the problems? So it may be large scale batteries instead. Great question. You know, I've spent the last couple of years looking at generators and looking at batteries and hoping that I could find a large battery enough to power the home for 3 days. They're just not up to the task yet. We are seeing phenomenal work on batteries, and there's no question they will get to that point. So I asked what the very wealthy people do, because I've been in touch with a good number of people who install these things, and they tell me they stack solar battery solar walls that power a battery. And so they'll use like 4 or 5 solar walls that are or power walls that are like $10,000 a piece. And that then powers their solar powers their generator. Or heat pump, and we have a heat pump, so it would solar power our heat pump and the battery to drive it. So it's an expensive proposition that not every household can manage right now. But great question, and soon to come.
Amazing. There are a lot of questions still coming. I want to be mindful of the time. And I think if you guys do have any questions, feel free to email our team. We love questions. but let me quickly share final slide. So that brings us to the end of today's webinar. On behalf of the Canadian Coalition for Green Healthcare, thank you all so much for joining us and for your thoughtful questions. A recording of the session will be shared with all registrants and made available on our website and YouTube channel soon. Thank you again to our amazing speakers for sharing their time and expertise. And again, if you have any additional questions, feel free to email us and check out our new website, which I will be adding to the chat. And again, thank you everyone and have a great rest of the day.